we have to have more people in administrative positions of power. We have to have more women and more Black women and more people of color, more women of color in positions of power in these hospitals as hospital owners and hospital administrators. Otherwise, nothing is ever going to change. It's the same in Hollywood. As long as you keep the people of color or the Black women down at the bottom of and there's no opportunity for executives in power that look like you, things will never change. So that, Nisha, has to really be a focus of how do we get women of color? How do we get Black women? How do we get them to the executive level, administrative level, so that people that look like you are in positions of power who we know are going to be much more willing to listen to what you're saying and create policy based on the needs and wants of women that look like you.
Yeah, I think we all spend so much time trying to fit into these molds that have been created for us. And usually they're created by people that are so demographically different than who we are. And we spend all this time and, you know, talking about sort of, Monique, what you were talking about with in terms of just self-awareness and knowing like, hey, these are actually things that I need and not what, like nobody has the right to tell me what it is that I need to be happy, right? And nobody is able to live my life and understand what it is that I need. And so it's funny because like what you were saying, I do a lot of coaching and consulting as well with physicians. And when they come to me and they're like, I'm unhappy at my job, I need to quit, I need a way out of medicine. I'm like, okay, but first we need to talk about what is it that you want, right? And it's been so long for so many people before, like since they've thought about what they want, because they've just been working within the system and being told what it is that they're supposed to do and what it means to be a physician or what it means to be a nurse. And so they kind of follow that mold. And if you there's this big fear that if you deviate from that mold, you're going to be taken as, you know, when I first started writing about a lot of this stuff in terms of burnout and just the need for cultural change in medicine, I can't tell you how many mentors from my time from, you know, university and things like that emailed me and were like, you cannot talk about this stuff. You are going to destroy your career. Nobody is going to hire you again. You can't like bring up these issues in medicine. Like medicine is an old boys club. You can't go up there saying, you know, like complaining about how you are pumping in hospital, like supply closets, because that's the only outlet you have that has a place that's, I mean, you don't talk about these things, right? That's what you were told, is you're not supposed to talk about these things. And yet, to all of your points in terms of if you don't come together and say, hey, this is unacceptable, right? That we are being made to feel guilty if we take maternity leave, or, you know, I when I was 38 weeks pregnant with my first, I was still pushing an ultrasound around the whole hospital during call, you know, and I didn't have the courage to be like, hey, this is maybe something that's not good for me and not good for my baby, because I was so scared of just, oh, okay, not only did she decide to have a baby during residency, because who does that, right? Like, I mean, that was what I was getting all around me, kind of being like, why are you having a baby so young? Like, you know, this is a bad time to have a baby. And I was worried about, okay, now I'm going to be giving my call to other people. So I've got to make sure that I cover all my call before I go on maternity leave. And I don't want to ask people for accommodations. And the same thing, like when I was nursing, and every time I had to ask to go to pump, I would be terrified of the, you know, the response that I was going to get, because nobody before me had stood up for those things. And so when I was asking for those things, you know, people were like, well, nobody's ever taken, you know, maternity leave for that long before. What do you mean you need that? What do you mean you're going to have a baby? What do you mean you're not going to X, Y, and Z? And I was like, well, these are things that I want. I'm owed them by contract, you know, I'm owed them legally, like, but you're trying to make me feel guilty for taking these things that I want or doing these things that are good for my family. And I'm telling you, I'm going to come back. I'm going to be at 100%. I'm going to do all the things I need to do. I'm not asking for shortcuts, but I'm asking for a little bit of understanding that maybe I'm a little bit different than the person who has a stay-at-home wife who's had 3 kids while he's been in residency. And yeah, he can be here all the time, but I'm going to need some accommodations for this amount of time so that I can do what I do really well. And I can also not feel as though I'm being forced to choose between my personal life and my professional life all the time. So I think that that's really important. Just a few points about what you guys were talking about in terms of just, you know, coming together, right? That's something for doctors that is really, really hard to do, because, you know, unlike nurses, we're not allowed to unionize. there's like, it's actually nationally illegal for us to come together and unionize. And so we cannot come together and say, hey, we're going to stand up against this. And, you know, I mean, during COVID and stuff, when people were walking out and different organizations were threatening, I mean, physicians can't do that, right? We don't, and not that we want to, right? Nobody wants to walk out on your patients or anything like that. But the amount of leverage that we have, because physicians have historically not come together, is very, very limited, right? So when COVID happened and everybody was freaking out and saying, they can't do this, like, we cannot be told that, you know, our lives are worth nothing and that we're going to be thrown into these situations and we don't have the right to ask for better protective equipment, or we don't have the right to say, hey, I have a chronic illness myself, maybe I shouldn't be going into that room right now. And we don't have those rights. You know, we basically, in our communities, right, we had 110,000 people that were sitting there screaming about, like, what is it that we can do to make sure that, you know, if you take out the front line, you know, a few weeks into this pandemic, because you don't take care of them, who's going to take care of people a year from now, right? And so it was really cool, because for the first time since I've been a practicing physician, I saw us all come together, and we actually were able to come together, create an act. I mean, we actually wrote a large document that said, these are all the things that healthcare professionals need to be able to focus on patient care during COVID. And these are all the things that you need to take off of our plate. And we actually created this thing called the COVID-19 Pandemic Physician Protection Act. And it says physician because it was created by physicians, but it applies to all healthcare professionals. We actually took it to Congress, and that was like the first time we were able to get funding for, you know, things that we had practices that were shutting down, because at the end of the day, physician practices are small businesses too, right? And they were encountering the same issues, and they were saying, wow, like, we're being asked to do all of this, but we can't stay solvent financially. And so we really tried to take all these things to the forefront and say, like, these are the things that you need to give us. And that was the first time. So myself and two African-American physicians actually out of Texas, Drs. Carlos Vital and his wife, Dr. Carla Vital, the three of us kind of came together and we took it straight to, like, top congressional leadership. And we're actually able to get some things and are still fighting for some things, but that doesn't happen very much amongst physicians, because we don't have that organized power that, you know, and like I said, there's less than 1 million of us in the United States. And so the thing that I keep trying to remind everybody when we're advocating is, well, okay, fine, there's less than 1 million physicians in the United States, but every single person in this country is a patient. And so we all need to come together and advocate for patient care, right? Like, we all need to be able to come together and say, it is really important that doctors and nurses and all the other healthcare professionals and members of the healthcare team are able to do their jobs and do it right, without just always thinking about profits and this and that. And the other one piece that I wanted to mention along that line, from the physician perspective, is, you know, what you were talking about in terms of finances. We're all very used to thinking about physicians, you know, 10 years, 20 years down the line, where they are actually very secure financially. But keep in mind that most doctors come out of training on average with $300,000 in debt at loans of 6 to 9%, right? And they've come out and they've had a whole decade, right? They're usually like in their early 30s by the time they start practicing. So they've given up on a decade's worth of earning money. They haven't put any money into retirement. They haven't, you know, have had any savings, and they usually are coming out with these large debt burdens. And so they don't have the power to walk away, right? And so that becomes a really big issue for early career physicians who are being asked, you know, in more and more in these employed situations where corporate medicine is kind of ruling how they do their jobs and what they do. And they find that they don't have much of a voice to walk away, because they've got, you know, thousands of dollars a month that need to be paid back towards their student loans. And so it has become a really big issue. And financial literacy, that for that reason has become such a big deal, because nobody tells us anything about finances. And I'm sure it's the same in nursing education, but I mean, certainly we know how to train really good doctors. We don't know how to train people that are financially and business savvy. Like, we do not do that well in our profession. And so we get these people who come out and they may make these salaries that are ostensibly big, but they don't understand compounding interest. They don't understand what that means in terms of their student loans and these mortgages. And they come out and the world is telling them that they're a doctor and they can afford all these things, and they don't understand how to budget, right? Like, and then they find themselves in these very, very hard situations in terms of, I don't feel like, you know, this is ethical, or I don't feel like this is in the best interest of my patient, but I can't step up against this, because if I lose my job, I've got 2 kids to pay, a mortgage to pay, and also these student loans to pay back. And so they find themselves in these positions where they feel very disempowered to speak up, because until they've paid off those loans, they really are in a position where, you know, there's no way to make those payments unless you're employed. And so, and the more and more that medicine becomes, you know, more and more people are employed physicians as opposed to in their own private practices, the more and more these like mandates come down from above from people who are not necessarily engaged in healthcare, right? I mean, we know the administrators are not there every day seeing what we see. And so for them, everything is a number. And for us, we're looking at these patients straight in the face and we're saying, you know, Monique, when you were talking about that doctor, like, obviously that was not a great situation, right? But also, like, it's hard for, I think that this is what we're creating, right? By putting all these pressures on healthcare professionals and saying, you have to get these things done or you won't get paid, right? Like, doctors have all these performance measures that they've got to meet, and they've got all these RVU requirements. RVUs are basically, for those that don't follow, like, you know, they're revenue value units. So basically we have to generate a certain amount of revenue for the hospital to pay us. You know, in a lot of people's contracts, you have to generate certain numbers. And so all of a sudden you're looking at this and you're saying, well, if I don't do X, Y, and Z, they're going to count it against me in this metric or that metric, and it's going to take away what and so everything becomes, again, it becomes like you're a machine. You're this robot that has to go through. And that's what we're doing to healthcare professionals across the board, whether it be physicians, whether it be nurses. The more and more that we put in these performance measures that don't necessarily tie with patient care and patient outcomes, but really just tie to how much money did you make for the hospital, the more we create this environment where people just look at it like, this has to get done no matter what. And then the humanism in medicine starts taking a back seat. And that's really scary, right? Because that's the heart of what we do. That's why we're good at what we do, is because we care. And you take that away, and patient care suffers, right? And all of a sudden these inequalities in medicine, right? When we talk about just health disparities, if it becomes that certain insurances are able to pay next to nothing and somebody has to create a certain amount of revenue in order to keep things afloat, then like you see physicians or, you know, practices making these decisions about, we're not going to take this insurance, or we can't do this because we can't keep the lights on if we take, you know, X rate. And so we really have to take a good look at where profits are going in healthcare and whether they're being allocated in the right direction to incentivize the results that are good for the whole population, or whether they're just lining the pockets of a few corporate CEOs and insurance companies or all of those things. And so, I mean, when you look at healthcare and you really dissect it down and what it has become over the past decade, there are just so many problems there that just feed into all of these problems, whether they be wellness, whether they be inequalities, whether it be, you know, just general health disparities in medicine. A lot of it comes down to, you know, systems that are not adequately incentivized to do the right thing.
And you know, when I was a little baby nurse, and I met this intern, and we actually compared checks, and he actually made less than me.
Yeah. And
I think that people don't usually know that. They think of, oh, doctor, and they think like you're automatically a 6-figure earner and you're this and you're that. Yeah. But he was telling me like, no, you make more than me. And I'm like, nah, show me. So he pulled out the check. I pulled out mine, and he made less than me. Wait, but there's more. He also had to pay probably 2/3 of that check to student loans every month. And he was like, you know, most doctors are from, well, I'm not going to say most, but that was his words, that a lot of doctors are from affluent families that can afford to take them through medical school and take them through the process. He said, I didn't have that. And I know that firsthand because I was pre-med at first and switched over because I knew I didn't have enough support to get through that. I knew I did. And people don't realize that part. They think like, oh, doctor, but a lot of doctors are not financially stable until they're 10, 20 years in, after they've paid off all their debt, become, you know, into their own practice. And then also they can't quit because I done invested my whole life at this point.
Yes.
I'm $300,000 in debt at this point. Whatever they say, I'm gonna do. And that, you know, it changed my outlook so that, you know, there's this like unspoken of sometimes feud between nurses and doctors, but I come on the flip end of it. And whenever I encounter a doctor who kind of gives me, rubs me the wrong way, I always ask them, are you okay?
Yes.
Do you need to call me back? Because we forget, like, yeah, our job is hard. We're dealing with 4 to 6 patients that may need our constant attention, but also physicians have a very hard job too. They may have 30 different patients that they're seeing overnight that they have literally a paragraph on. They don't know the patient intimately. They don't know what's going on. And they literally have 20 calls per minute from somebody asking them for this, that, and the third. So before I get defensive and get right back with them with the, who are you talking to? I'd be like, you know what?
Empathy.
Okay. Do you have a moment? Do you want to call me back when you have more time to talk? You know what? When you come to the floor, I'll talk to you. I'll just text you what I was going to say. You know what I mean? Because half the time, that's the problem with administration, is that I have to say that I spoke to you about things that don't matter. You know what I mean? But I still...
Empathy, yes. And I see an opportunity to say her name, Breonna Taylor. I think Breonna wanted to be a nurse.
She did.
And working as an EMT to pay her way through nursing school. So we have an opportunity there to say her name. So we are saying her name.
Breonna Taylor.
Breonna Taylor. We actually, so fun fact, Breonna Taylor got her posthumous BSN degree or RN, like RN. So there was like this little, you know, what is it, sign link that I sent out for like University of Kentucky to recognize her for her posthumous BSN degree.
Oh, you did?
No way.
Yeah, I want to say crazy because
That's so cool.
Very personal to me. But like, I don't know about you, Sheena, but like, it just made me feel like that could have been me. You know, like that one hit. I was in, Carter called me this morning, like, are you still coming? Because I was in bed sobbing all day yesterday because I really feel close to that, you know. I have a question for Nisha, if you guys don't mind.
Yeah.
You said something that really stuck to me because you talk about all the ways that you're undervalued as a resident, right? Or an intern or things like that. And like, first of all, I loved my interns and residents because you, like, working at teaching hospitals, I worked with neurosurgeons. And people think often they have this really negative stereotype of having like a God complex and things like that. But I loved my neurosurgeons because they really cared about their ICU nurses because I was the one doing one-on-one neuro checks and things like that. And they would be asleep sometimes at night because I worked night shifts. So we had a really beautiful balance with each other where they were not micromanaging me, asking me. They trusted that I would not call them unless it was an emergency or if I needed them. And if it was, they answered immediately and I wouldn't call them out of respect because they needed their nap at night. But my question for you is, when you were in that kind of vulnerable state of being a female, being a young female, being a female of color and being pregnant as a like, you know, training still in medical school, what made you empowered enough to ask for your full maternity leave, which I think probably ultimately saved your career?
Yeah. I mean, I think I've kind of always marched to my own drumbeat, and for better or for worse, I think, you know, I've shaken a few, I've been the cause of one too many discussions probably on the administrative level that I don't know about. But I mean, the way that I see it is
all that good trouble.
Well, and it's funny because now I actually have residents from that same program who are kind of like, thank goodness, or, you know, faculty at the same institutions that I were at were like, thank goodness you crossed that path because it would have been really awkward for me to do it. Right. And I think for me, like, I've sort of always kind of just been like, whatever's going to happen is going to happen, but I'm not willing to give up on X, Y, and Z. And I think it took me a while to get to that point. I think for the first part of my, look, until I wanted children, I played by all the rules basically. And then, you know, and then I had this child and I was kind of like, listen, like, I owe something to my child. And at the end of the day, the hospital doesn't love me back, but this child loves me back. And I'm there, you know, I shouldn't have brought them into the world if I wasn't going to take care of them and advocate for them and be who I need to be for them. Right. And I think at that point, it really empowered me to just kind of be like, listen, like, at the end of the day, they can replace me, but nobody can replace me for my child. And so I am going to step up and say, this is what I need. If you can't make this happen, I will find another way, right? Like, and I think, again, that whole know your worth thing becomes really, really, really important, right? And I like, if you're on My Communities, you'll hear me all day, know your worth, know your worth, know your worth, because people find themselves in these situations. I'm like, you need to stand up for yourself. And so, you know, at the end of the day, I was like, okay, I've got like a really great resume. You know, I know I can be employed somewhere. It may not be this place. Maybe this institution is going to step back, but I've got a plan B, and I've got a plan C, and I've got a plan D. So at the end of the day, if I want to have children now, I'm going to have children now. If I want to be able to get out in time, you know, so radiology, the field that I'm in, is very male dominated, right? I think it's currently about 26% are females, maybe. And so there's not, and especially, and a lot of those are younger, right? I mean, in older generations, like the department that I was in when I was on faculty as a musculoskeletal radiologist at UNC, was all male, and they were all, you know, they were all white males who were many like decades ahead of me in practice, right? And so when I had my second son, and I was like, well, listen, like my husband works, my husband's a surgeon. He at the time was working over 100 hours a week easily. And I had these two children, and I was like, I need to take care of them. And every day for me was like, literally, I would wake up in the morning. My husband would have already left because he would leave 4 o'clock in the morning, 5 o'clock in the morning to round. And so I'd wake up, I'd get my stuff ready, I'd get the boys ready. You know, I'd get their lunches, I'd get everything together. I'd drop them off to daycare. I went to work. I'd come home, or I mean, at the end, like by 4 o'clock or so, you know, daycare closed at 5:30. I knew I had to be there by 5:30. Nobody was close to being done with work where we were by 4:30 or so. And I'm trying to ramp down, right? And so many of those days I'd be like, okay, I know I need to get my kids by 5:30. We didn't have a nanny. We didn't have the finances to do that just yet, you know. And so, you know, my husband was still in training, so he was still making that awful paycheck, and I was making a salary, but I was in academics, and, you know, academics don't make nearly as much as private practice physicians do. And so things were still a little bit tight. We still had student loans for both of us. And so, you know, we didn't have that kind of help. And so I would be trying to rush to try to finish so I could get the kids on time. And then a lot of times I would have to get the kids, take them back to an outpatient imaging center right near their daycare, where I could finish doing my work while they like sat on the floor and played together while I, you know, and my youngest one at that time was 13, 14 months old. You know, he was young, and he's sitting there on the floor. My other one's sitting there. They're kind of playing together. I'm trying to finish my work. I bring them home, and then, you know, I've got to get dinner together, feed them, clean up, you know, get them to bed. And then I open up my computer, and there's all the stuff for my grant or like my research, or I've got to write a letter for a medical student or whatever. And that was my day every day for 3 years, you know? And at some point I was like, I cannot do this, right? Like there is no reason. And our mornings are always in academics a little bit slower because the residents and the fellows will do some of the reading in the mornings, and you wait so that you can approve their work. But so for the attendings, it was pretty slow. And I kept being like, why can't we do some of this work in the morning? You know, like, why do we have to stay here at 6 p.m. doing this on non-emergent studies? Why can't I read them in the morning when the residents are doing the other stuff? And that way I can like not have to take my kids to this outpatient imaging center every night. And everybody's just like, well, that's just how we do it. And I was like, yeah, I understand, but like all of your kids are grown, you've got stay-at-home wives, whatever the situation is, like that's not my reality. And there's no reason for me doing this the way that we're doing it. Like I'm going to start leaving at 5, and I'm going to get my kids, and I'm going to, you know, I can drop the kids off a little bit earlier at daycare in the morning, and I will come in and I'll finish the work in the morning, but I'm no longer going to do this. And everybody's just kind of like, did she just say no? Like, and I was just like, yeah, I just said no. Like,
I love a woman with boundaries. Like, I'm such a fan of boundaries. Like, that's so dope. Like, I think that's so, I love that. I love that because just,
so many things in healthcare we do because we always did, but it doesn't necessarily mean anything. And I think that, you know, what you said also kind of brings us back to standing behind each other, because I just want everybody to know when a nurse gets sick, passes away, or their family members get sick or pass away, we donate. We create the GoFundMe. We put the care package together, not the institutions. So that goes to show you, stand behind your fellow coworkers, because they're the ones that are going to help you or be there to aid you when things go wrong. Administration, don't get me wrong, some administration can be very helpful and very useful. But when it comes down to it, it's usually us that cover your shifts and maneuver things around to help you be able to take care of your sick mother or cover or these things. We're the ones that help with that. And when it comes down to it, I know so many nurses who are holding on to the sidewalk as they walk down the hallway because they have an injury, that are trying, even me, like I used to pump every 4 hours when I first went back after having my son. I went back to work when my son was 6 weeks old. I wasn't ready. My stitches were barely healed. My doctor literally said, like, you probably shouldn't go back, but I'll sign it. And I'm like, all right. I went to work that night, exactly 6 weeks to the date that my son was born. I was pumping inside of a manager's office. I'm a pool nurse, so my manager isn't on the same floor that I work on, but I float to different floors. And I never forget that one nurse manager that said, no worries, you don't have to go down to the maternity unit in a little pod and take an extra 10 minutes for that. Go in my office, pump, and that way you can go back to the floor easier. Those little things make you feel cared for. They make you feel loved. They make you feel like you can do this. Now I can do this. You know I have a safe space to pump. It's close to my patients. If anybody needs me, those nurses that took my phone and said, if anybody calls, we got you. Or I worked up until my last days. I was feeling like I was about to fall over some days. Those nurses that were saying like, no, we got it. Don't sit down. You need a nap. Okay, go ahead. Take your half an hour. If the supervisors come, we'll cover for you. Those things are what's important. So we are a community, nurses, doctors, sticking together and not thinking of ourselves as individual units against other, like what? No, we're a community.
And Sheena, along those lines, like, I think that one problem that is so prevalent in medicine is this tendency to kind of be like, wear it as a badge of honor, kind of what you've gone through, and therefore be like, because I've gone through it, therefore everybody after me should go through it, right? And so, like, for the pumping thing, I just remember, I remember so many female physicians telling me, well, like, I just chose not to pump my child, and your child will be fine if you give them formula. And I was like, I get it. I understand they would be fine. But I've made this decision that I want to do this. And just because like you didn't want to, detract from your clinical time or ask other people to have to cover you, and you made the decision, or because, a few years, like decades ago when you had children, you were the only female in your department, and therefore like you could not ask for things like time to pump, doesn't mean that we should then, for every generation of female physicians or female healthcare workers going forward, say, you know what, just because we didn't do it and we took that sacrifice upon ourselves, therefore everybody else should do it. And that's not just pumping, that's everything, right? But it was amazing to me actually that when I actually felt like the males were more supportive of my pumping than the females were, because the females had kind of like been like, well, we did this and we got through it and we made it work, and so you should just make it work. Whereas, and I don't know if the males just didn't want to have to hear about pumping and wanted to like no talking about pumping, so they were just like, get out of here, you go do your thing, or if they actually really were like, no, this is important. My wife did this for my children. I want her to be able to do it for her children, or what it was. But I actually got a lot more resistance. And this is not just for this particular topic, but for a lot of things, like in terms of decisions that I've made throughout my career where I may have prioritized my family first, where I got a lot more pushback from other female physicians about the choices that I was making than I did from male physicians. And I think that that's really important in terms of just sticking together and saying, hey, like this sucked for us. We want it to be different for future generations of healthcare professionals. And like, we're not going to perpetuate this culture where everybody just like self-sacrifices all day long.
I've been on both sides of that. What you're saying, and there's like a thread through this whole conversation, which I'm so into, by the way. I'm so a happy place. The thread is that these institutions have been set up not for us, right? Whether it's the school to prison pipeline or healthcare or whatever it is, I'm seeing a thread here that it's the way these systems have been set up and who they have been set up by, number one. Number two, I've been on both sides of what Nisha is speaking about, where I felt like two things. I felt like in my, to younger actresses coming up, well, and I'm guilty of this, and this is where we have to have self-awareness and check ourselves and say, well, I used to do 100-hour weeks, when we first started the show, and no one's ever worked as hard as I've worked in the first 4 years of this show, and everybody else burnt out, and I'm still standing. So if I did it, everybody can do it, which isn't what you should be thinking, which isn't correct way, but I think that that's the synapse or whatever happens, that's immediately what we go to. And then on the flip side, I've been so then what we have to have self-awareness and learn from that and say, I need to learn from, instead of wearing it as a badge of honor as a woman, no matter what your field is, instead of wearing it as a badge of honor, you have to say, well, this is what I was meant to deal with, and how can we change it for other women going forward?
Mm-hmm.
And I think that we don't have, I certainly definitely have experienced a lack of compassion from other women too. So that's the other flip side of it, is I've had a lack of compassion because of what I've been through. And then I also have experienced a lack of compassion from other women for whatever reason, whatever their reason is. I can't speak for them, but so I think it all comes back to self-awareness and trying to take into consideration other people's shoes, how they're walking through their day, and what makes them think that way, and how we walk around that can set an example.
And I think that recognition is just, I mean, I think all of us have a tendency to impose our own experiences on other people. And so I do the same thing sometimes, where I'm like, oh gosh, like they're complaining about this, like try doing what I did for these years and blah, blah, blah. And we all do that. But I think like ultimately, the further and further I get along with this, and I deal a lot with like some really heavy topics like physician suicide, and you know, physicians have the highest suicide rate of any professional group in the country. I mean, it's bad, right? Like over a fourth of physicians will say that they know somebody who has committed suicide amongst, you know, from their colleague group. I mean, it's really, really scary, the degree, because mental health is just not prioritized in healthcare in general, and amongst physicians in particular. There is just a very large stigma associated with mental health problems, and then on top of that, our licensing boards and our credentialing boards place a lot of emphasis on, you know, there's some things that are actually quite punitive when it comes to reporting that you've had mental health care issues of any sort. So you may be subject to random drug testing. You may have to fill out different things for your credentialing. There's people who like will put you in probationary status on medical. I mean, there's all this stuff that we have in the system that really discourages physicians from saying that they have a mental health issue, because it can prevent them from being able to do their job. And so what happens is a lot of people suffer in silence, right? A lot of people will not say things, they will not step up. And then to the point where, you know, substance abuse rates amongst physicians are higher than the general population also, despite the fact that they know better than anybody what the ill effects are, right, from these things. Because a lot of people will self-medicate or will, you know, kind of wallow. And then the problem is that when you don't get that out, when you don't get help, when you can't get help in a confidential way, when it could potentially jeopardize your career, is that all of those things spiral. And then by the time that people catch it, it's often too late. And so, you know, the number of physician suicide stories that I've heard, even in the past few months, that have been exacerbated by COVID and just the isolationism and everything that's happened as a result of that, are just, they're terrifying. But I think when you hear those stories, you start realizing that no matter who you speak to, no matter how much they have it together on the outside, everybody is fighting their own battles on the inside. And I think that is just so important in terms of giving each other grace and giving each other compassion, and really trying to understand, like, you may look at somebody and think that their scenario is ridiculous for X, Y, and Z reason, and you were able to do whatever, but you don't know what's going on in their lives on the outside that makes that particular battle hard for them. And so, you know, as much as I can now, I feel like everybody that I talk to in any sort of capacity with any of this stuff, I kind of try to take a step back and not say, well, oh yeah, I get that experience. I did that. But you want to do that in terms of the commonality, but you also want to realize that they had their own struggles in the background. And just because something was successful for you or worked for you doesn't mean that particular thing in terms of wellness or in terms of, it just might not be their reality, right? And I think really having that perspective when you're talking about wellness in general, is really important to just say, what is wellness to this person, and what are the issues that are actively taking away from their wellness? And it's not a cookie cutter solution, right? You can't tell everybody if you do yoga, you're going to be great. Like that's not going to work for everyone, right? And the one other piece that I think is super important, just to, I think Nurse Monique did like a great job of just touching on so many of the things in terms of self-care. But one of the things that I like make very, very clear at institutions is that you cannot put all of it on the individual. Because if you want to create a sustainable healthcare system, at the end of the day, so I have this analogy that I always tell, and maybe hopefully I can make you guys understand it. So I'm a musculoskeletal radiologist, right? So I do a lot of looking at fractures, and there's two categories of fractures. One of them is a stress fracture, and one of them is an insufficiency fracture. So stress fracture is abnormal stress on normal bone, right? That's your 26-year-old college athlete who decides that she's going to run 8 marathons over the course of 2 months, and then she gets a stress fracture, right? Because her bone is just physiologically not like built to handle that kind of stress. And then you've got your insufficiency fracture, which is when grandma like comes over, trips on your kids' Legos and breaks 5 bones because she's osteoporotic, right? And so when you're dealing with those two sorts of fractures, the solutions are different, right? When you're dealing with a stress fracture, you got to rest that bone, right? That person needs to stop running marathons for a little bit so that their bone can heal. Whereas in an insufficiency fracture, you give them bisphosphonates, you give them all of these things to build bone health, right? Your calcium supplements, all of these things. And I keep saying to everybody at these institutions, I'm like, physician burnout is a stress fracture. It's not an insufficiency fracture, right? We've all been through the ringer. We've gone through a decade of training that is like ridiculous mentally, physically, emotionally. Like, I mean, everybody here that's watched Grey's Anatomy knows kind of what that process is like. I mean, it's not that you're not strong people. You're probably stronger than the general population because you've been exposed to so much. So your problem is not that you need, like, yes, everybody in the world can benefit from resilience. Everybody in the world can benefit from stress management. All of the things that Monique was talking about, those things are all super important. But at the end of the day, they're not enough, right? At the end of the day, you also need the institutions to say, what is it that we are going to do to change and take something off of the plate of all of these people who are feeling all of these things? Because medicine has always been a challenging profession, right? I mean, 30 years ago, physicians were working even more than they're working right now. So it's not that people aren't equipped to deal with that stress. There's a lot that's changed about the healthcare system that adds to those stresses, right? I mean, the average physician, and I'm sure nurses probably even more, for every hour of patient care that a physician spends, they spend 2 hours charting. And that's the statistic. I mean, you're on your computer, you're recording, all of these things that have changed, right? It used to be that you did paper chart and you would say certain things, but now you've got to fulfill billing requirements, you've got to fulfill, performance requirements, you've got to fulfill institutional, all of these things. And so you are spending so much time doing things so that insurance companies can pay, or, calling insurance companies and saying, yes, I really do need an MRI for my patient. They actually really do need that. You shouldn't be denying it. And you're spending a half an hour of your time on the phone doing that. And all of those things compound to a point where you really are putting a lot more pressure on members of our healthcare system now than they had before, when they could primarily focus on patient care. And I think you guys would agree, like, there's so much about medicine now that is not about face-to-face contact. There's a lot that's about paperwork and, fighting for the rights of your patients. And if you as an institution and you nationally, as like in terms of policy, don't start taking some of that stuff off of people's plates, you will lead to people burning out and people leaving medicine and people saying, hey, this isn't worth it. I don't know what the statistics are like for you guys, but I think the most powerful physician burnout statistic is that 70% of physicians would not recommend a career in medicine to their children.
Wow.
And I think that is like so scary, right? Because at the heart of what we do, we all love it, right? We've spent 10, 15 years training to do what we do. And we love the science, we love the patient care, and we cannot look the people that mean the most to us in the world in the eye and say, you should follow in our footsteps because it was worth it. And that's scary, right? Like, when you start thinking about the sustainability of the workforce, if 70% of physicians are saying it wasn't worth it, like, I would not recommend it to my children, that's really, really, really scary. And you start thinking about who's going to take care of all of us, 20 years from now and 30 years from now, like, we're in a terrifying state of things. I mean, physician burnout and physician wellness and healthcare professional burnout and wellness, these are actual public health crises. Like, people don't necessarily see it that way because they think of it as, you know, kind of hooky, like wellness, whatever. But these are things that have longstanding implications for the sustainability of our healthcare workforce. And that's why they are so important.
And I think people forget how many jobs in one that people do. Like, I know as a nurse, we your mammy, your pappy, your friends, your therapist, your physical therapist, sometimes the doctor, sometimes the pharmacist, your daggone social worker, nutritionist. Like, we literally do all the jobs in one over a 13-hour shift, you know what I mean? And people don't realize like how much we do. The normal, like I know like for people that work for like government jobs, they get a full hour break plus a half hour for every 8 hours that they work. Right, yeah. For every 8 hours that they work. Meanwhile, when I used to have my Fitbit on, I used to literally clear 10 miles in one shift.
Yeah.
And that's just from walking back and forth. And that's why we say yes.
Okay, that's why.
Our job is so athletic. It's so athletic and so physical on top of the mental and on top of the COVID mental was
and the emotional and all of it.
Yeah.
I do think that it's not only an institution thing. I think it's kind of like a social issue as well and an entertainment issue as well. So let's think about this, right? So we watch these shows about like medicine and things that go on, and we see how hard they're working, and we kind of glorify and glamorize it. And we don't always talk about like, oh, this person is having like, I know your show covers it, but this person is having like real mental health issues. This person is not able to see their family. Let's talk about how hard that is. And, you know, this is the first year ever, the year of the nurse, that healthcare workers have been glorified in this sense. And I think it's from a really negative light, in my opinion, because you guys are calling everyone on social media and the internet are now calling nurses health heroes. And to me, there's nothing heroic about putting your life and your family at risk. I think it's actually quite damaging. So I think that we do need to shift the narrative around making healthcare providers be superhuman, because they're not. They can get COVID. They can get sick. They do need to rest and take maternity leave. So I think there's like a humanizing element that has to take place around healthcare providers, where they talk about openly, where we talk about our mental health issues, where we talk about our burnout, where we talk about our lack of understanding for like why we're doing all this, why we're working these hours. There's been this sense of martyr mentality around healthcare providers. I actually got slandered for publicly saying these COVID conditions do not work for me. There's not enough PPE. I'm not going back to work. I'm financially stable. I'm going to sit this one out. Y'all be great. I'll be here to mentor you guys, talk to you guys throughout this, but this is not what I want to do. And like on the internet, a lot of people were like, you're a waste of space. You should go and walk in the hospital. And to me, that's this complex that is saying that if you have this training, if you have this skill set, that you're not allowed to put yourself first, that you are superhuman and you have to put yourself first. And I really think that that's just a sense of toxicity. Ellen, I use you as an example to a lot of my clients because you recently did an interview that really was inspiring to me. You talked about your choice to not leave Grey's Anatomy.
Yes, I read that one.
Jamel?
Huh?
On Jamel? Was it on Jamel Hills?
Yes.
Yeah.
And the reason was because the schedule worked for you to be with your kids and the pay was great. And I was like, wow, how empowering, a woman saying, these are my standards and these are my rules. And like, yeah, absolutely, you're a phenomenal actress. There's a million things you can do. You can go be Superwoman. You can go be Spider. Like, it doesn't matter. You can do so many different things. But you said, no, this is what is important to me. And this is what works for me. And you didn't feel the need to like explain it so much. And I think if we took that mindset on more with healthcare, and it became more more normalized to the public to say, hey, this is not okay. I'm not Superwoman. I'm not I'm a hero. I get it. But I also can get sick, and I'm also a human, and I also have needs for my kids. So I think that has to change. And I also think that will help institutions kind of pick up on the fact that, oh, wow, we are kind of dehumanizing our staff and our physicians and things like that. Because, you know, I've worked with doctors that are on 24-hour shifts. Like who can do that? That's obscene.
Of course they have an attitude. They're tired.
I'm not waking you up unless the patient's on fire. I'm sorry.
Right,
like,
but I'm just saying, but some institutions promote that.
Yeah,
some
they do.
Institutions promote that. They make you call because the patient refused a heparin injection. They promote that. They make it a big deal. So a lot of the nurses feel like they have no choice. When your manager is coming to you saying you need to do X, Y, and Z, and if you don't, you're going to get in trouble. That's what it is. And that's why I say a lot of the things that we do, we've always done, but it doesn't mean that it's the right way to go about it. We can recenter healthcare to make sure that it fits everyone and it's not just so administration focused. I remember when I was a little baby nurse and I was going to my director and telling them like, listen, like this is not working, this is not right. And I got told, oh, well, if you can't cut it here, then it might be another place for you. No, baby, no one can cut it here. This ain't right. This ain't right. You ain't right. We got 5 patients, 2 admissions a night. We down 2 CNAs. This is not okay. And this is why you got falls and people calling at left and right. This is the problem. So I think it's all about people putting themselves in other people's shoes and not just being so closed-minded. And, you know, I know we're at this point, we've been on here forever, but, you know, just to close, I feel like that's what comes down to empathy. It comes down to looking at other people's situation and thinking, okay, how can I support this person? Because if we all support each other, the only way we can go is up. Because we're concentrating on everyone's role. And even with, you know, bringing it back to Breonna Taylor, a lot of people probably don't feel like they see themselves in her, but we should. Are you a woman? It don't matter if you're a woman of color. Are you a woman? Are you a medical professional? You know how it is to sacrifice your life every day for other people, and to have people who are supposed to protect and serve come into your home and kill you is a lot. It comes down to, you can have empathy because you're a human who sleeps at night and doesn't expect to wake up with 6 bullets the next day. That's what you can have empathy for. You don't have to look like me to have a place in my struggle and to understand my struggle and to support my struggle. And sometimes having a place in that struggle is just taking a moment to sit and listen so that you can hear and actually physically understand, instead of listening just to hear, listen to actually advocate and think of what you can do to support someone else, not always understanding that you're going to relate the same way as everybody else. So I think that, you know, this whole conversation came down to self-awareness, self-love, self-care, self-worth. You know what I mean? And advocating for yourself, creating boundaries to your world, creating outlets to your world so that you cannot be controlled by anyone. By saying, I'm financially stable, I have other outlets. So therefore, if this doesn't work for me, I can move on to another situation. But it all comes down to us feeling loving ourselves enough to know, I don't want to leave this job broke down. I don't want to leave this job not mentally or physically capable of taking care of myself and my family. And I come first because I have to come first in order to take care of other people.
And I think that that's the big point, is that so many of us feel as though we're supposed to self-sacrifice. And the way that I think a lot of us can feel comfortable with that idea that we do need to practice self-care is really understanding that by doing that, we are taking better care of our patients, right? We cannot be who we need to be for our patients unless we take care of ourselves. So if you were still going to play the martyr, you still need to do self-care because you still need to take care of your patients.
Yeah. You play the martyr, but still support others that don't want to do that. Mind your business. You don't have to worry about, no, but seriously, people be so like, oh, well, I did it. Okay, I don't want to do it your way. And you can support other people moving in a different direction that's healthy for them. We always talk about take care of yourself, do this, do that, breastfeed your child, do this, and then we don't, as healthcare professionals, allow that to be somebody's actual truth. We just talking a whole bunch of mumbo jumbo, but no real policies in place to really get those things done.
Only thing I want to say is that the media, again, makes self-love be a very glorious thing. And I talk to my clients about this all the time, is that you think that healing is about like putting on face mask and getting your hair done and getting a bubble bath. And sometimes it's not really like that. Sometimes it's laying in bed and like just crying like I did yesterday. And the only way that we're really able to find out what we need and to really like hold that space for ourselves as well as hold space for others is to sit with ourselves and find out like, and allow ourselves to feel. It's been so
allow ourselves to be human, right?
Yeah, allow ourselves to be human. I think about like in my 20s, some of the like wild stuff that I would find out. Like I would find out like my dad was sick, or like my ex-boyfriend would start a crazy argument with me, and then I would go into work and share that energy with other people. And sometimes we have to just check ourselves and be like, oh wait, I'm not okay, instead of just being like, you fine, keep going. So I think it's really important that we understand, like, to sit with ourselves, let ourselves be human, and understand that self-care looks completely different for every person, and it ain't always cute. That's all.
Thank you so much for saying that. And just to wrap up, I want to say that this is an example right here of leadership. For anybody watching this Zoom, these conversations, these type of conversations is what leadership looks like. We have problems in administration, which could be beyond our control or could not. What we want to say to administrators here is help us help you, right? Monique, to your point about how I was able to sort of set boundaries for myself as I work for women. I work for women, going back to my point earlier of how these systems were designed and who set them up. I work for women who allow me to have that schedule, who allow me to make those choices. I couldn't make those choices and set those boundaries for myself if institutionally our production wasn't set up by women, right? So I'm not saying that women should rule the world, even though we should. I just want everybody watching this to see that leadership is in you. Leadership isn't something we should look to. Leadership is something that we should pull out of ourselves and take initiative, start conversations, come together and own our power and enlist people to hold all the torches and to hold the power together. We are natural born leaders. We are multitaskers. And I am so grateful for both of you making the time, Monique and Nisha, for making the time out of your busy schedules to have these conversations, to spread the love and empower healthcare workers. This is the work, right? I tell people all the time that, it's exhausting. People get exhausted about having to do whether it's social justice work or everything is exhausting. But the truth is there's work to be done in every room we walk into, not just for racial equity, not just in workplace equity, everywhere, right? And the good thing is we're women, we're, like I said, great at multitasking. So this is the work, just these little conversations. And we can inspire other people to have conversations. Hopefully so many people watch this. And I will say to everybody, I have a community app on my phone. So if there's any people in healthcare that have questions or want to continue dialogue, we're going to list everybody's bio and links in this post so that hopefully you can reach out to Monique and reach out to Nisha and further these conversations. Encourage people to watch this conversation, encourage people to reach out to everybody and continue these conversations. And it's one step at a time. We just have to put one foot in front of the other and make change. We're not going to change, institutions overnight. Rome wasn't built in a day, but what we can do is we can empower ourselves and have conversations and inspire change. So thanks so much to everybody. You guys are fantastic. I appreciate this so much. And I love you all. And hopefully we'll talk again soon.
I hope so too.
Thank you, everyone.
Thank you.
Thank you.
All right.